Hello everybody, my name is Dr. Irwin Goldstein. I'm Director of San Diego Sexual Medicine, Director of Sexual Medicine at Alvarado Hospital here in fabulous, beautiful, sunny San Diego, California. I'm President of the International Society for the Study of Women's Sexual Health. Today, we are going to be doing a webcast called Success Stories, Team-Based HSDD, Hypoactive Sexual Desire Disorder, Care Management Environment. So I just want to move to the next slide and state that in this slide, I was at a meeting at the International Society for the Study of Women's Sexual Health. It was in Charleston, South Carolina. And one of the speakers was Geert Holstek, and he's in the Netherlands. And he stated in his topic that hypoactive sexual desire disorder is not magic, that it's about hardware in the brain. And I thought that was a very fabulous use of words, and I steal it and I use it all the time in my talks. That no matter where you come from, whether this is psychologic, whether this is hormonal, whether this is neurologic, whether this is brain neurochemical imbalance, it's not magic. All the abnormalities that result in HSDD, from the psychologic sphere to the biologic sphere, is all really about the brain and the brain's hardware. And I will go to my death with that belief stated by Geert Holstek. Now, what is some of the evidence that brain blood flow changes when there is interest in sexual desire? That's this slide, and we'll go to the next slide, which will show some pictures of brains during the various phases of the sexual arousal event. So at the beginning, during excitement, you have this side of the brain with the blood flow as red in different views. And as you start to go towards increased arousal, you change the regions of brain blood flow. When you go through orgasm, interestingly enough, there's actually absent blood flow in the brain. It's an interesting phenomenon. And then in the refractory period, you revert back to the brain blood flow at baseline. So you can see that during the various cycles, there's changes in blood flow. As we move to the next slide, you'll see again in an article in Neuroscience, the healthy brain during sexual arousal has lots of brain blood flow, but the brain of a woman with hypoactive sexual desire disorder has markedly less brain blood flow, as depicted in the Neuroscience article. And yet another evidence-based data set, this shows increased brain blood flow in women with no history of sexual dysfunction, NHSD, and in women with hypoactive sexual desire disorder, you can see marked difference in the degree of brain blood flow comparing the NHSDD to the HSDD group. As we go to the next slide, another brain blood flow study. This is actually by Geert Holstek, and I'll use the pointer to show his name here. In the healthy without sexual dysfunction woman, on the right side of the brain, lots of brain blood flow. In the woman with HSDD, less blood flow. And there's another aspect to the regulation of the sexual interest paradigm, and that's turning off brain blood flow to specific areas of the brain that are involved in multitasking. So on the left side of the brain, there's absent brain blood flow in the healthy person, so that person can focus on sexual activity. But in the woman with HSDD, she cannot turn off the multitask area, and she thinks of many things during sexual activity that would distract and cause low sexual interest. So in summary, there is a lot of brain blood flow redistribution. It does not matter what is causing your HSDD, but at the end of the day, brain blood flow is a critical aspect to getting healthy sexual interest. The messages in the brain blood flow all act through the neurochemical glutamate, G-L-U-T-A-M-A-T, and we're going to follow the glutamate changes during sexual activity. So if you have increased glutamate activity, if you have a lot of glutamate activity, especially in the part of the brain called the prefrontal cortex, you are on a state of survival. You're not in a state of reproduction. In essence, your brain has two ways to go: to survive and to reproduce. When you have increased glutamate activity, you will have low dopamine, low norepinephrine, and low sexual desire. So the people with HSDD have too much glutamate, leading to bad neurochemical issues as it relates to the sexual activity. So serotonin is one of the neurochemicals that regulates the glutamate issue. So there's a receptor called 5-HT1A, so it's 5-hydroxytryptamine 1A, a serotonin receptor 1A, that when you activate it, it decreases glutamate. So from the point of view of desire, activating 1A receptor is a great thing to do. But serotonin has multiple receptors to act upon. Another one is the 5-HT2A receptor. However, activation of this receptor will result in increased glutamate. So serotonin has the ability to both decrease and increase glutamate, and from the perspective of desire, what you want to do is activate or agonize the receptor 1A, but you want to antagonize or block the receptor 2A, which without it being blocked will increase glutamate. So in summary, just a way to remember it, elevated glutamate is about survival. It's the same as having low interest, which is what you want to have when you want to survive. But low glutamate is what is a reproductive part of the brain when you have sexual desire, and you can't activate your multitask area in the presence of low glutamate. So enter the brand new drug, 8/18/2015 at 7:30 p.m. Eastern Standard Time. This drug was approved by the Food and Drug Administration, the first drug outside of a hormone, non-hormonal strategy to raise sexual interest. And what does pimavanserin do? Wow, it increases the agonizing activity of 1A, which will decrease glutamate, but it's the first drug, really, that we know that can block 2A receptors, which will now both synergize to decrease glutamate, thereby increase dopamine and norepinephrine and increasing desire. This is called an MSAA, multifunctional serotonergic agonist-antagonist, the only drug of its kind, and it's the first drug in history to actually take on the concept of re-regulating the imbalance in neurochemical activity relating to desire. So in this news slide, hypoactive sexual desire disorder is an imbalance between central inhibition, which would be serotonergic, and central excitation, would be dopamine and norepinephrine, and specific and critical brain nuclei. And it really doesn't matter if this is a biologic thing or a psychologic thing. It's all the same. It doesn't matter. In a psychologic context, you will have the same imbalance as you would in a regular situation. Now, this is an enduring material that we wrote in a Mayo Clinic's preceding article coming from the International Society for the Study of Women's Sexual Health, a consensus meeting where if you look at this part of the brain, which is a consciousness awareness part of the brain, that's the prefrontal cortex. If the reds beat the greens, so the stops beat the goes, a negative inhibition will happen to the VP area, to the medial preoptic area, to the pituitary area, the ventral tegmental area, and these will allow somebody to be in a survival mode with multitasking. But this is bad from the perspective of sexual interest. If you want sexual interest, you want to allow the PFC to not be activated so that these areas can now allow sexual activity to occur. There's a limbic integrator, there's a reward area, there's a conscious area, and these balance of chemicals is what regulates the issue of sexual interest. As we get to this slide, where there reemphasizes the biopsychosocial nature of low interest, it doesn't matter where it's psychologic or hormonal or CNS-based. The idea in all management plans is to interact with the chemicals to change the ability for glutamate to be low so that the prefrontal cortex will work appropriately, the nucleus accumbens will work appropriately, medial preoptic area will work appropriately, the ventral tegmental area will work appropriately, and what I'm saying is the greens will overwhelm the reds, the chemicals that activate the reflex will work. So what I'm going to go forward is now give some examples. In a woman with no history of sexual dysfunction, so she is fine at some point in her life, she will have brain blood flow on the right side and brain absent blood flow on the left side to shut down the multitask area. If she gets generalized acquired HSDD, she will have less blood flow than she wants. She can't turn off the multitask area. We do a treatment, a biopsychosocial treatment, either it's psychologic, hormonal, or CNS agents, and our job is to increase blood flow to the right side of the brain and decrease blood flow to the left side of the brain, and that's based on glutamate, and that will result in improvement. So I have 5 stories to end this slide talk. This is a woman who sent me a testimonial. She said flubanserin had changed her life. She had this HSDD for more than 10 years. Taking testosterone was helpful to her, but she felt she was back to square one this summer. She let her husband fall asleep. She was waiting for sex to be over after the few minutes of activity. She had no interest. She got her prescription for flubanserin. This is an MSAA, multifunctional serotonergic agonist and antagonist. It stops the activation of the prefrontal cortex. And now, she wanted to have sex because her husband is very sexual. She had a great sex life when we were younger. 1 week on the prescription, she's no longer avoiding sex. 3 weeks on the medication, she's starting to think about sex. 5 weeks on the flubanserin, she recognized she was young again. She was no longer her age. On flubanserin, she had the ability to take control of her sex life. She was having great sex 9 out of 10 times. You were hoping when you're older that you have sex, that's great 1 out of 10 times if you're lucky. She anticipates, she initiates, she enjoys sex, and she's happy to be where she is. And that's the idea of the agent flubanserin in conjunction with hormones and in conjunction with sex therapy. Next woman. As you know, I've been struggling for some time with declining interest. Hormones help slightly, mostly with natural lubrication, but not much at all with interest. Anxiety medication helped a little bit with response, but not with interest at all. Sexy bits of a novel I would skip, finding them boring, and a painful reminder of what she wasn't anymore. So it is with a mixture of shock, relief, and joy, I find my eyes straying as my husband steps out of the shower, my heart speeding up as he looks back and not being impatient for him to get home from work. During sexual activity, the act itself is way more fun, no longer boring or worse. It is so much easier to get to orgasm and to enjoy the journey there. I also notice that in our day-to-day interactions, it's easier to focus on affection and pleasure in my husband's company rather than the hurts we have dealt with each other that every couple experiences with HSDD. Again, this woman has an MSAA on board, the flubanserin, which allows her to not turn off the various parts of the brain so that she can activate, as we discussed before, her chemicals and lower the glutamate and allow things to happen in a positive way from the perspective of sexual reproduction, which is the issue here. I cannot believe the difference now that I'm nearing the end of my 2nd month of flubanserin. I'm actually initiating sex. It is so amazing. I've not initiated in at least 20 years, maybe longer. I orgasm faster, more intensely. I lubricate as soon as I'm aroused, which is amazing. It used to take a while for that to happen. We used KY jelly when we had intercourse, which is only once a month. Last week we were on vacation. We had intercourse 4 times. In a normal week, I love this word, I supplied my husband with an orgasm about twice, but normally did not have intercourse. That is not happening at all anymore. Flubanserin is making me so happy. Another woman who prior to the use of flubanserin had this neurochemical imbalance, and flubanserin allowed the neurochemical imbalance to go in the direction of reproductive brain activity, not the usual in HSDD survival mode of the brain. Another woman, fulbanson was a life changer for me and my husband. For the last 5 years, I had no sex drive. My husband is very affectionate. I would limit touching him for fear of giving him false hope that it would lead to sex. What I couldn't understand is why I had no libido when my husband still turned me on after being together for 22 years. I hated myself for it, but I didn't know what to do. Again, this is not a disease state, it's just a chemical imbalance. So for this woman, why she hated it, she had to rewrite her chemical imbalance if she wanted to do anything about it. Fulbanson worked for me within the first 2 weeks of taking it. I still drink wine at night, and fulbanson helps me sleep. I never took a honeymoon when I got married, and we are now going on a honeymoon in May. We are so happy. It is spilling over into so many areas of our lives. I just can't express enough the importance of the work you are doing and how many people you are helping. Well, it's the drug fulbanson. We're just able to prescribe it, basically. And this is my last slide of the talk. I started taking fulbanson almost 3 months ago. I didn't notice any interest in my sexual desire in the first 6 to 8 weeks, so I figured I would be lumped into the no responder category. But Dr. G encouraged me to continue to take the medication for a third month, and it was during this third month that I noticed an increase in sexual desire. I've made a few other lifestyle changes, again, getting back to the biopsychosocial things. She added testosterone. She eliminated unhealthy carbs and sugar. She exercised more. And there were several experiences in the past few weeks that were out of the ordinary, meaning I wanted to have sex. I was thinking about wanting to have sex. My body was physiologically responding to those thoughts. As a result, my level of sensitivity, arousal, and lubrication has improved. Improved lubrication is important because I'm prone to UTIs. I suppose the most notable change is that I've been looking forward to sex and initiating sex, which has never happened before in my relationship due to, I love this phrase, soul-crushing HSDD. At some time in my life, healthcare providers and doctors will realize that HSDD is not a punishment, it's not magic, it is a hardware issue, getting back to the original part of the lecture from Irwin Goldstein. It is hardware, and we have the ability to change the hardware through biopsychosocial issues. It's a pleasure been talking to you this morning from San Diego. God bless you all, and I hope that you learned something from me. Thank you very much.